Hello, everybody, and welcome to today's workshop. I'm so excited to have you here with us. Once again, I am Michelle Jones with Full Plate Living. If you have not found the chat yet, I would encourage you to go ahead and do so at this time. You can write in your name or tell us where you're from, or maybe tell us why you're excited about today's workshop. And of course, I'm excited because today we're talking about sleep, especially for those of us that are already in these midlife years. We know that sleep does get more difficult. And so I'm excited to have Dr. Valerie Cacho with us today, and she's going to help us get slightly better sleep during this time of our life. We do want to try to get to some of your questions. So if you have questions during the workshop, go ahead and type them in the chat. We will mark them as questions and address them at the end. So before we move forward, I do want to read Dr. Cacho's bio very quickly. Board certified sleep and integrative medicine physician, Dr. Valerie Cacho is the founder of Sleep Life Med, a sleep medicine clinic in Hawaii and California, and Sleephoria, a digital resource for women's sleep health in perimenopause and beyond. A Castle Connolly top doctor, she specializes in evidence-based holistic solutions for women in midlife. Her mission is to help women overcome exhaustion through practical tools and lifestyle, transforming chronic fatigue into sustainable energy. Now, that sounds exactly like what we want, Val. So thank you so much for being with us today. And I'm going to go ahead and turn things over to you.
Thank you so much, Michelle. Happy to be here to talk about one of my favorite topics, sleep during perimenopause and beyond. So the title for today is The Sleep Gap, an integrative approach to exhaustion in perimenopause and beyond. Thanks you all for being here and joining us today. So thank you, Michelle, for reading that really kind bio. Yes, I'm certified in integrative sleep medicine. Just quickly going to define integrative medicine. I am a sort of Western trained physician. I went to medical school, did training in internal medicine, a fellowship in sleep medicine, and did extra training around integrative medicine. The way I like to describe it is all the things that we know can help someone heal that we don't learn in medical school. So we learn about things like herbs, nutrition, Chinese medicine, acupuncture, sort of the whole gamut of healing properties throughout the world. We also learned in that. And I like to incorporate that because I think it's really important to know more than one way to help my patients improve their sleep. So as a quick summary, I help people who can't sleep or are too sleepy. And so if you are interested in checking out more of the work I do with Sleephoria about women's sleep health, you can check this QR code here. We'll show you some videos about that over on YouTube. So let's get started. Some things that you'll learn today. Number one, the real reasons women struggle with sleep during perimenopause and menopause. Spoiler alert, it may not really have to do too much with your magnesium or melatonin, things I see talked about online a whole lot. We're going to talk about holistic approaches for women's sleep health. If I saw you in my clinical medicine practice, either in Hawaii or California, what's my approach to help someone improve their sleep? And then actionable tools. So things that I know really work through helping women over a decade now improve their sleep health and regain that energy again during midlife. So thank you so much. And again, as Michelle said, please drop your questions in the chat and we'll get to as many as we can at the end. So this statistic is pretty staggering. 16 to 60% of women struggle with sleep during perimenopause and menopause. So if you take the higher end, right, more than half of us are struggling with sleep. That's really just not acceptable. I'm just going to put that out there. It's not acceptable. And sort of like why I'm here, because I think there's so many things that we can learn to do to help improve this. So before we begin, I love to do a little audience participation. We're going to play a little family feud. And I'm part of an online group on Facebook. It's called the Peri Hub, where I didn't actually put this post up, another person did. And we asked the audience, what were your most common struggles with sleep? So the question is what do women in perimenopause say about their sleep? So I covered up all the answers here, and in Family Feud fashion, what do you think the top three are? So there's 33%, 25%, and then 15%. Does anyone want to put in the chat? Someone said interrupted sleep, hot flashes, anything else? Racing mind, yep. Waking up at 3 a.m., waking often, bathroom breaks, yeah, poor diet, low energy. Yes, yes, yes to all of the above. So survey says the top answer was actually I wake up at night and cannot get back to sleep. So those early morning awakenings, those 2 to 4 a.m. awakenings, what's going on with that? The next answer was I feel exhausted even after sleeping. So maybe you're part of the group of folks who they can sleep through the night, but even after 7, 8 hours, even 9 hours of sleep, still pretty tired. What's going on with that? The third is, oh, this one is pretty common. I think something I'm guilty of. Sometimes I just can't fall asleep because my mind won't shut off. So constantly turning and turning, mind racing, the car motor's going and going and going, and it's time for bed, but yet our brains are still running and running. Night sweats. Believe it or not, night sweats was not part of the top 3. When I give talks, I always like to say hot flashes, night sweats, they have really good PR. Almost it's synonymous with menopause, having night sweats. It's sort of a common thing that I'm trained in medical school about, but it's actually not the most common thing when it comes to sleep. The next is waking up too early before the alarm. And then the last is restless legs or body aches keeps me awake. So, right, a survey of a perimenopause group with over 100,000 people talking about the top complaints that they have. And it almost sounds like it tracks what the audience says in the chat here. So thank you much for those who participating. So the reasons women struggle with sleep during perimenopause and menopause. And so this is a little bit of a compilation of things that I've seen in my medical practice and also what the research shows. We're going to start off with 2 cases. So MA is a 52-year-old woman with no real medical issues. She comes to see me. A lot of what I do in my medical practice on a day-to-day basis is talk about obstructive sleep apnea, which I put here as OSA. So sort of just technical terms, mild sleep apnea. AHI just represents how many times an hour someone has difficulty breathing, and that's based upon the muscles of the tongue relaxing and collapsing. Anything above 5 is positive. But really her main concern is she's just tired. She's really exhausted throughout the whole day. And she wants to know what to do about this. And even if the sleep study was really significant, she's like, I did it at home. It's just this thing on my wrist and on my finger. Is this even a legitimate study? And will treating my mild sleep apnea help improve my energy? When we talk to her a little bit more, I like to think of it as pulling back the layers of the onion. What else is going on in your life? So she does have hot flashes. Her mood is going up and down. It's labeled. She has decreased libido and fatigue, which are all also signs of perimenopause and menopause. And another thing that she's had for a long time that she barely even mentioned, but I always like to ask about pain that keeps you up at night, is that, her back hurts. And she thinks, oh, I just need to get a new mattress for this. And so what do we do? Well, since I'm a sleep medicine doctor, first and foremost, we're going to treat the obstructive sleep apnea. So she tries this automatic CPAP machine. This is what when the machine does, depending on how your airway collapses at night, it can deliver a pressure. But, she just didn't tolerate it. She tried several different masks and it felt like it was making her have more insomnia. So she decided, okay, maybe this just wasn't for me. Then she saw a menopause specialist who talked about hormone replacement therapy or HRT. She started an estrogen patch and a little bit of progesterone. And I think probably the biggest thing for what I can tell is she took her back pain more serious. She changed up her mattress and started physical therapy. During her 1-month follow-up, she said that she's sleeping a lot better. She has more energy and is so grateful for her consultation. And yeah, so technically her mild sleep apnea wasn't treated, but the other factors that I like to think of part of her sleep pie, the hormonal changes and her back pain, I think really helped improve her overall sleep quality. So that was sort of an interesting case. Case 2. So this is a lady who is 46-year-old who comes to me with depression, anxiety, comes for an insomnia visit for at least 4 years. So she recently moved to the state after she divorced with her husband, and she's currently looking for a job in IT. Her depression is controlled. She has a little bit of anxiety about sleeping, but otherwise she's doing pretty well. She's been working with her primary care physician and a psychiatrist and is on some medications, hydroxyzine and mirtazapine for sleep, which helps a little bit, 4 to 6 hours. Her goal, though, is not to be on any medications. Yeah, already before bedtime, she's meditating. It helps her fall asleep. She's really into her health. So she exercises daily. She's a pescatarian, eats a lot of fruits and veggies, and she's already on hormone replacement therapy and doesn't have all the typical signs and symptoms such as hot flashes, decreased libido, dry skin, and joint pain. And now she comes and asks, okay, Dr. Cacho, What else can I do to help stay asleep, wake up refreshed? And her overall goal would be not to need to take anything for bed. So this one's a little bit different from the previous case and almost made me think a little bit more like, she's already on hormone replacement therapy. She's already meditating. Like, what am I going to do? Well, the mainstay of treatment for insomnia is something called cognitive behavioral therapy, which we'll talk about. And we really took a look at the thoughts that she has that's actually keeping herself up. Sometimes there's no significant stressors that I'm able to find in patients, but sometimes it's just anxiety around sleep. Some people have really lost a lot of hope in their ability to fall asleep and stay asleep. And I always think it's like their confidence is broken. And so part of what I like to do is help build them back up. For this particular patient, she also had a lot of worries about not getting a job. And that was also keeping her up at night. And so, even though she already had a regular meditation practice, she was unable to stay asleep until we actually did the cognitive restructuring. So, cognitive is the way you think about something, which affects the way that you feel, which affects the way that you behave. So, we learned to shift her thoughts around the medications for her sleep and then also her future career plans. I'm also trained, since I do integrative medicine, on something called clinical hypnotherapy, which is another tool in the toolbox where we can help the mind improve thoughts around sleep by telling the subconscious mind that you're actually a great sleeper. Yeah, so it's a form of guided meditation where someone will listen to this over and over and over again. It tells their subconscious mind, you're actually a great sleeper. You can fall asleep and stay asleep. And she did a session for that. So within a month, believe it or not, she was actually off of her medications and she was sleeping 6 hours. She was really motivated to make this work. She wished that she could sleep a little bit longer than 6 hours, but was really happy that she was doing better overall and she didn't need to rely on these medications. So yeah, it's really interesting. And I think these two cases just sort of exemplify how straightforward or how complex it can be for a woman in midlife when it comes to sleep. So this is a really interesting article that talked about why we have nighttime awakenings. I think, and as in the chat, hot flashes and night sweats, are very prevalent. Yes, they are, but I would say I don't see it too often in my clinic. I actually just spoke to someone earlier before getting on the call today, and she's like, my sleep apnea is great, but now I'm waking up with a hot flash. Okay, yes, it's certainly out there. Mood disturbances is also something to consider. In medical school, one of the signs of depression that we're trained to look for is actually early morning awakenings. Sometimes anxiety can also keep you from either falling asleep or staying asleep, because anxiety, what happens when you're anxious, your brain is going and going, and that's sort of the opposite of sleep. Sleep happens when our brain waves slow down. And then the next, what I really want to focus on today's talk is talk about medical sleep disorders, specifically OSA and RLS, which can lead to exhaustion. OSA is obstructive sleep apnea. And then restless leg syndrome is that uncomfortable, creepy, crawly sensation that happens before you fall asleep. So that's restless leg syndrome and causes insomnia. So medical sleep disorders are pretty common, but not always talked about. I'm going to put this here too. If you want to answer, please do. Do you know that women snore too? And many don't even realize it. So did you know that women snore too? And many don't even realize that they do. Yeah. So snoring in women, if you can see this cartoon picture here, imagine you're cut in half, picture from the side, air is going in through the nose to the back of the throat, down to the lungs off screen. What is snoring? Snoring is just partial collapse of the airway, sort of like whistling, right? If you are really congested, you can snore through your nose, or if you have a deviated nasal septum. It can also be if your throat is really small in the back, or I think as someone spoke, if I'm sleeping on my back, because what's happening on your back, gravity is stronger at pulling back the tongue or the muscles of the upper airway. So snoring is sort of like whistling. Anytime air goes through a narrow tube, it can make a noise. And believe it or not, snoring is not normal. I'm putting this journal article here because researchers actually wanted to test if women did in fact snore and to see how loud it was, because some people actually believe that women don't snore, and also they don't snore as loud as men. So they studied a lot of people, right? 1,900 people is a lot of people in the lab, right? And that's the best way we can detect this, because there's actually microphones and you can measure the decibel levels. So they did discover, these researchers found that women snored just as loud as men. And a third of women who thought that they did not snore ever actually had severe or very severe snoring intensity based on the decibel, which is sort of interesting to me. Conclusion, women underreport that they snore and also like don't think it's very loud. I think socially, it's not acceptable, I think, for women to snore. I have a lot of women who are in midlife who want to go on girls' trips with friends from high school or from college. And some of them are a little embarrassed because they don't want to be the one that snores and have their friend complaining. And that's why they're seeing me, because they're like, I heard that you're on the machine, or maybe there's a mouth guard or something I can do to help. And I need this figured out before the summer, before I go on my girls' trip. Yeah, so it's sort of interesting of why people come in and see me. So CPAP machine, this is what a mask looks like. And yes, women in fact do snore and have obstructive sleep apnea. So let's focus now in on obstructive sleep apnea, or OSA. First off, it's very common. Adults, 1 in 5 of us have it, which, right? If you take a look at how many people are here in the room, that's a lot of folks. And if you compare rate during menopause as opposed to those premenopause, it doubles to triple that. And often goes undiagnosed in women. Some of the research suggests 90% of women who potentially have obstructive sleep apnea aren't even diagnosed, which boggles my mind. It makes me think, man, we need a lot more sleep doctors to help make this diagnosis, because it's out there. For one thing, it's not commonly discussed. 12% of patients start talking about snoring and sleep with their doctor. At the same time, primary care physicians or primary care providers, about a third of us are talking about sleep apnea with their patients. And, there's a lot of different reasons for this. When you go to your primary care doctor, I would say sleep typically isn't on the list of things that they need to check off, right? It's your mammogram, what's going on with your blood pressure, your cholesterol. Have you got your colonoscopy? Do you still need a pap smear? So there's a lot of things to do. And sleep hasn't been, I think, put on that list of things that we should be checking. Definitely on the top of my list. But if your doctor hasn't spoken to you about sleep or even your breathing at night, I hope things change after listening to this talk today, this conversation. So I do encourage everybody to talk about snoring and obstructive sleep apnea with their doctors or advanced care practitioners, because it's really common, especially if you have a hard time staying asleep. And let's talk a little bit more about the signs and symptoms. So loud or regular snoring, daytime sleepiness, unrefreshed by sleep, increased fatigue, nocturia, which is waking up to urinate, choking or gasping, dry mouth upon awakening, morning headaches if your body mass index is above 30, if you have a crowded airway, and then depending on your neck size, if your neck size is above 16 inches, you have a higher risk for sleep apnea. But I wouldn't let the absence of these not preclude you to not get a sleep study. I saw a patient who had a lot of palpitations or regular heartbeat. And she saw online that, obstructive sleep apnea could be a potential reason why. And she spoke to her cardiologist, and the cardiologist basically dismissed her and said, you know what, because your neck size is very thin, it was under that range of 15 to 16, he didn't think she needed a sleep study. So she found me, and lo and behold, guess what? We did a sleep study and she did have obstructive sleep apnea. So a lot of times women don't actually fit the mold, but could have obstructive sleep apnea. So what are the typical symptoms in women? I think I heard a talk by a sleep doctor who's also women's sleep, and she says we should stop using the word atypical for women and talk about what's actually typical for women. And so women, if they have obstructive sleep apnea, sometimes their main symptoms are just waking up with a headache, or mood issues like depression. If you're really tired, you can be sad. Anxiety. Sometimes people just are worried about their ability to sleep because they have a hard time staying asleep. And that could be really anxiety provoking. Another is fatigue. If you're waking up multiple times at night unconsciously because you're not breathing well, oh yeah, you're going to be pretty tired throughout the day. Another one is vivid dreams or nightmares. And this one's a little bit sneaky. And I'm going to explain to you what's going on. We have 4 stages of sleep. Stage 1 and 2 are light. Stage 3 is a little bit deeper. And then there's rapid eye movement, which is REM. During REM is when we have our most vivid dreams. And so when we have our vivid dreams, actually our body's paralyzed, so we don't act out these dreams. Our diaphragm is still moving. But when our body's paralyzed, even our tongue and the muscles of the upper airway are relaxed more, we have more sleep apnea events. So if you're in REM, you're dreaming, you're waking up, and then you're remembering your dream more because you're not breathing well, it can be really scary. So sometimes I actually had a patient who The only reason she saw me was because she had vivid dreams and she was waking up with palpitations. No snoring, gasping, or choking. Lo and behold, she had pretty moderate sleep apnea. Once we treated her, these things went away. Waking up to urinate more than 2 times. A lot of us drink a lot of water, which is great. I have some people who stop drinking water at 4 or 5 p.m. They don't go to sleep until 10 p.m. And I think, oh man, I feel that's like so torturous because that's what they've been told to do, right? If you drink too much water, you're going to wake up to pee. Well, guess what? If you're not breathing well at night, think of it as a backup of your plumbing. If you have a narrowing in the pipe here, downstream, there's more pressure in your lungs. More pressure in your lungs puts more pressure in the heart. The heart will stretch and signal for you to wake up to urinate, right? You become a lighter sleeper overall. So the signals for you to stay asleep and not have to wake up to urinate aren't really there. So again, untreated sleep apnea can actually lead you to wake up to urinate more at night. Yes, believe it or not. Insomnia, having a hard time falling asleep or even staying asleep, could be from untreated obstructive sleep apnea. And so I'm circling these things here because I myself was diagnosed with obstructive sleep apnea and I didn't even think I could have it. I was having symptoms of having a morning headache, and I was relying on coffee pretty heavily. But I was also a new mom. My daughter was about a year old and I was working in a hospital that was really, really busy. And I was just thinking, oh, it's just my job or my lifestyle. And that's why I'm so tired. 3 conditions that mimic obstructive sleep apnea. So some of the research suggests if there is a woman who goes and sees her primary care provider and says that they're tired, going to get a blood test for checking their thyroid, maybe start on an antidepressant or sent to a therapist, or maybe just told that they have insomnia and it's because of the life that they're in. So these are the classic 3 conditions that mimic sleep apnea, or maybe are the conditions that women are underdiagnosed with or diagnosed with instead of obstructive sleep apnea, versus if a male counterpart came to see their primary care doctor and they have symptoms of fatigue, classically because they're more likely to store and stop breathing, they're getting sent to the sleep lab or to do a home sleep apnea test. And honestly, it's just because the way research works, we didn't study a lot of women. Yeah. Hormonal changes during menopause can cause hot flashes and night sweats that wake you up at night. Again, there's a lot of overlap, I think, through perimenopause and menopause symptoms and also obstructive sleep apnea, because if you're not breathing well at night, that can cause a huge spike in adrenaline and cortisol. And when that happens, guess what? You can feel really hot. So you can have night sweats that come from untreated sleep apnea and also from changes in hormones, specifically estradiol or estrogen, because that affects our temperature. So a little bit of biology here, just the curves of what's going on with our hormones. As time progresses, our bodies decide we don't need to have babies anymore. And so estrogen or estradiol and progesterone, which are seen here, drop. And then the hormone FSH starts to rise. So you may or may not have heard, well, if you're still getting your periods, maybe your doctor doesn't want to order any blood work because, or you maybe already had blood work and they said, oh, you can't be in perimenopause because all your blood work is normal. Well, guess what? Yes, that's true, because up until you stop having your period for a year, the hormones are shifting. Estradiol and progesterone can be going up and down, right? Which means that you can have all the symptoms of hot flashes, decreased libido, night sweats, mood instability, joint pain, vaginal dryness. Those are all part of it, but the labs can be completely normal. Average age of menopause in the US is 51. But they say that we can have symptoms 10 years on either side. Most people are maybe 4 to 7, and it's not until you actually go through menopause, which is 1 year without having your period, that the blood work may show positive, which is estrogen and progesterone go really, really low, and FSH, which is the follicle stimulating hormone goes high. Yeah, so labs may not show the whole picture. So as your estrogen levels go down, you may have trouble falling asleep, wake up in the middle of the night. Why is that? Well, to keep things simple, estrogen can actually affect your melatonin, believe it or not, and also can affect your serotonin, which affects your mood and sleep. And then also, let's see if I put it here, progesterone. I didn't have a slide for progesterone. Progesterone is known as sort of the relaxation hormone. It works on a protein in our brain called GABA, which is a neurotransmitter that helps support the sleep. Other things that work on GABA are things like Ambien or Xanax that help us feel more calm. So when we have lower rates of progesterone, that can cause us to be lighter sleepers. This is one of my favorite slides to share. It's the perimenopause and menopause sleep disruptors. Listed are the common contributors to sleep disturbances. Which one do you have? Sometimes I show this to my patients and they look at it and they go, yes, I have all of them. So, right, hot flashes, we talked about mood changes, we talked about circadian rhythm disorders, we didn't talk about too much, but basically that's, are you a night owl? Is your true bedtime maybe 2 or 3 a.m., but because you have to wake up and go to work by 6 or 7, you're trying to put yourself down at 9 or 10, but on the weekends you fall asleep fine if you went to bed at 2. Obstructive sleep apnea, which we really spoke deep about, waking up to urinate, which we discussed, waking up with pain, which we talked about in the case. Sometimes environment can be such a huge contributor. I had a patient that I worked with recently. A lot of my patients are in Hawaii. Depending on where you are on the island, there can be a lot of roosters. And so her sleep was so disrupted because the roosters were sort of roosting or making the noise that they do, the cock-a-doodle-dooing at like 3 or 4 in the morning. It wasn't until she actually moved house to a different part of the island where, man, her insomnia was almost cured by the fact that the roosters were quiet. Also, another thing to consider is as you're getting older, if you have a bed partner, they're getting older too. So if they're getting older, their muscle tone is decreasing, maybe they're snoring, and that could keep you from sleeping as well. Insomnia is just difficulty falling asleep or staying asleep. We'll talk about treatment options for that. Ruminating thoughts, stress, and overwhelm. I think there's something about midlife where the thoughts just get really augmented. Maybe it's hormonal changes, but I think it's just women have a lot on their plates, especially I think I read that in your 40s, it's the most exhausting decade. If you still have kids that you're helping them, maybe your parents are getting older, maybe you're at a point in the time in your career is peaking or there's a lot of demands. And there's just a lot going from all sides. And so there's certainly a lot to think about at night. So shifting gears here, another sort of Venn diagram. Again, I just like to show pictures to patients and they tell me what's going on. Is it the family, the kids, the aging parents, the household demands on top of your own health, the hot flash of the hormones, feeling fatigue, or is it the career? And you can see how it all can interplay and affect how we feel. And when it comes down to is that magnesium, yes, glycinate can really help maybe calm down the legs, maybe help you feel a little bit more calmer, but it's not like a cure all. And so yeah, I would say careful for the things that you learn online. And if you have questions, please reach out. But there's a lot of folks that'll sell you something, and it's not always so clear that's in fact what you need. Yeah. So let's change gears here. Second objective is how do I approach women's sleep health? So if someone comes to my practice, what am I doing? Well, I'm asking them those questions, right? We're talking about the family life. We're talking about the career. We're talking about all the things in the environment and talking about things in the body. And I just really ask a lot of questions. Do you have a hard time falling asleep? Do you have a hard time staying asleep? Or is it a combination of both? And if I don't think they have restless legs or obstructive sleep apnea, we really go deep into something called cognitive behavioral therapy for insomnia. Because if I can teach you how to sleep, right, it can do so much more benefit than taking a medication or a supplement or, sort of relying on alcohol or cannabis, where maybe that sort of helps, but it's really not a sustainable long-term goal. The first step is, understanding sleep science. Why do we sleep to begin with? What's going on in our brain? What's going on with the biochemistry? Stimulus control and sleep hygiene. I'll put these sort of in the same bucket, right? Are you using your bed just for sleep and intercourse and when you're sick? Or now is your bed sort of like the recliner, or, it's the place where you're eating or reading or working. Sometimes that can really make the brain confused. We really want our beds to become magnets. We see our bed, we go to sleep. Sleep hygiene, I feel like most patients that come and see me with insomnia, their sleep hygiene is impeccable. They have all the tools, they have the white noise machine, they have the special blue light blocking glasses, they've tried all the oils. Yes, certainly those are helpful, but I would say it's not the whole story. What I found really helpful, which I alluded to in one of the cases, is talking about cognitive restructuring. The thoughts that you have about sleep are either helping you or not helping you go to sleep. Sleep restriction, this sort of goes a little bit along the lines of stimulus control, where we give you a certain bedtime. Some people are in bed for 10 hours, but they're only sleeping for 5 hours. So when we calculate that as your sleep efficiency, how much time you're asleep versus how much time you're in bed, it's about 50%. the more we can increase that time in bed where you're actually asleep, the better you feel. And some patients actually will stay at 5 or 6 hours of sleep, but now their sleep efficiency is about 90%, and they just feel so much better because now they're using their bed as just a place to sleep. Lifestyle factors. Yes, I love talking about lifestyle factors, especially food, because sometimes people don't realize how what we put inside of our bodies, even though it's in the morning or afternoon or evening, can affect our sleep quality. My first talk with Full Plate Living, we talked a little bit about this more, and I love how it's fiber forward because yes, fiber has been shown to decrease awakenings at night, right? Processed foods, you actually can wake up more. And then, of course, everybody knows about alcohol and caffeine. And I would encourage you, if you don't know if those are affecting your sleep quality, is do a little experiment. Just stop caffeine after a certain time. For me, I have to be very cautious. I can't even drink coffee or black tea too late. So I try to cut it off at 10 a.m. Sometimes when I forget or make bad choices, I'm up till midnight and I'm thinking, oh, it was the caffeine that I didn't realize. Sometimes switching to herbal tea in the afternoon will really help. It's going to be different for everybody in terms of how fast you actually break down caffeine. Sometimes it's 6 to 8 hours. Sometimes it's more than 20 hours for certain people. So if you don't know, it just, go a week without it and see what happens. And then relaxation techniques. I think it's so interesting now with today's technology, there's a lot of ways for us to be entertained. And even there's a lot of great tools for relaxation. But sometimes if we're using our phones both for entertainment and relaxation, it can be a little bit confusing for the brain. So if you do like to read at night, I would encourage you to use paper books, get a little lamp with more of the amber hues to it so you don't have that bright light, or use a Kindle. I have my Kindle here, which is really handy, I think. So it really fights me when I don't need to go on social media at night. My brain still needs to relax, so I like to read. All righty. So for those of you who are struggling with insomnia, this is what I share with my patients. CBTI approaches are first-line evidence-based, even for people in menopause, believe it or not. I'll talk about why in a little bit here, but you can take a picture of this. There's a really good book called Say Goodnight to Insomnia. For those of you who are more into mind-body practices, I recommend this book, Mindfulness for Insomnia. And then this app is made by the Veterans Administration. It's called CBTI Coach, which is completely free. And some people can follow these if they're self-directed learners and really improve their sleep quality. This is a study performed in 106 women over 8 weeks. And the women who were studied were in perimenopause or in postmenopause, so 40 to 65. And they had moderate insomnia based on a scale, the insomnia severity scale, and had more than 2 hot flashes daily. And so what the researchers were looking at in one group is just learning about insomnia treatment, sleep science, the things I went over. And then the other group was just learning just about menopause, right? So traditional CBTI does not include any type of menopause education. And what they found out was that those who learned about cognitive behavioral therapy for insomnia actually dropped their insomnia score by 10 points, which is pretty phenomenal, which is a huge difference. And the results continued on 6 months later when they tested them again. Also, the folks who were in the cognitive behavioral therapy for insomnia group, they had hot flashes, but they bothered them less. And so I think that's phenomenal because CBTI traditionally doesn't include anything about hot flashes, but sometimes it's in the reframe, right? When you're learning about the situation, the way that you frame your thoughts around something, it's really remarkable on how that can help with physical symptoms on top of that. But also I think just when you get better sleep, your tolerance for things just goes up. So that was pretty powerful. So hormone therapy and sleep quality. This could be a whole talk in and of itself, but I just want to include a couple of slides here where we actually reviewed 15 studies and found that estrogen and progesterone therapy certainly can improve sleep. Right now, hormone replacement therapy or menopause therapy is not an FDA-approved treatment, but if you do have hot flashes, which it is at night, it certainly can improve sleep quality. Participants reported like they felt like they slept better. So these were more of survey type studies where we actually didn't necessarily study these folks in the lab. Sometimes just being on progesterone alone. Again, I spoke, progesterone works on the GABA system. One study looked at over 400 women taking a natural form of progesterone called micronized progesterone. So it's similar to the chemical structure we put in our bodies, that women fell asleep 15 to 30 minutes faster than before, and didn't necessarily make them sleep longer. Their whole sleep duration wasn't longer, but for some people, falling asleep within 15 to 30 minutes is a lot better than 1 to 2 hours. And then in terms of medical services, of how much can be given, anywhere between 1 to 300, but sometimes it can be pretty sedating. So depending on where you are in your cycle, maybe you need more or maybe you need less. So definitely, this is all education. If you are thinking about being on this, go talk to your doctor or even someone who specializes in perimenopause and menopause, and they can help guide you. So again, my approach to helping women in midlife sleep, I like to ask, do you have a hard time falling asleep, staying asleep, or both? What are your health goals? Because it's got to be in the context. I can give you a great plan, but if you don't really are interested in following that plan, it's probably not going to work out so well. And then sometimes the conversation gets really extensive, and I just say, all right, now pretend I'm your fairy godmother, bibbidi bobbidi boop. If I could wave a magic wand and improve your sleep, what would that look like? Because for some people, it's just sleeping 6 hours and that's it. And some people, it's like, actually, I want to have more energy to go on a trip with my daughter. Or maybe it's, I don't want to snore when I go on this trip with my daughter. And so it really helps me hone in on, okay, how can I help the person in front of me improve their sleep? All right, so mind, body, and soul, right? We are a component of all three. And if I just focused on sleep apnea alone for that initial patient and didn't even think about, the back pain or her mattress, we probably would have skipped a lot of things or even ignored those hot flashes that was bothering her. So a multimodal approach is necessary. So when we think about, mindfulness, going to a spa, maybe that'll be helpful. So self-improvement, relaxation exercises. Also, one of my favorite things to do is just recommend journaling, writing down your thoughts in a book. Another thing is moving your body. Exercise is so helpful. Bringing in your diet, what are you eating? I think restaurant here, sort of reminder, when I tend to eat out or have takeaway, typically the food is a lot saltier. And in those times, I actually wake up in the middle of the night being really thirsty. And it's like a fight. Oh, do I just ignore this and go back to sleep? But if I drink water, then I know later I'll wake up to go to the bathroom. Or do I just plan around that? And if I'm going to have takeaway or go out to eat, can I do it on a weekend instead of during the work week where I have to be busier and have my mind more focused? So sometimes planning out what you're eating is really helpful. Psychology, right? The thoughts that you have are really helpful. So cognitive behavioral therapy or even clinical hypnotherapy are really good tools for insomnia, but also for perimenopause and menopause. And one of my favorite things to talk about is self-compassion. A lot of the women that I see are doing all the right things and they feel like nothing is working. And it's the way that they talk to themselves about their sleep, where your body is not broken, your brain is not broken. You're just going through a chapter in your life where sleep is different. And guess what? There is a way forward. There are things that will work, and together we'll find something that works for you. So this is a picture of the pillboxes in Kailua. I like to put these here as like a mental reset. And now our last slide is the last one, the last objective. We're talking about actionable tools. So sometimes when people ask me, what's the one thing you want all women to know about their sleep? And I would say prioritize it, right? Everyone here on Full Plate, they learned about healthy, nutritious eating. So yeah, I think we've done a really good job of discussing the importance of food and nutrition. But I think from a sleep standpoint, we still have that, oh, I'll sleep when I'm retired, or I sleep more on the weekends, or, sleep is for the week. But, it's really hard to be productive when you're sleep deprived. And so as much as possible, and I think everyone who's here is here because they want to learn about sleep. So if there's one thing I can leave with you is please prioritize your sleep health. Because guess what? If you're sleeping more, then you can move your body more. You're going to think more clearly. You're going to be more efficient at work. You're going to be more present with your family, right? Because your mood is going to be more stable. Be your own detective and take an active role of tracking your symptoms. And start with one thing. Like if you're going to start just with your food, okay, how does what I'm eating and the timing of my eating affect my sleep, right? Or another thing, if you don't want to do your food, is your exercise. How does the kind of exercise, how long I do it, the timing of I do it affect my sleep. Another thing that you want to start with maybe is your stress, right? You know, do I sleep better on the weekends, or do I have the Sunday night scaries where, man, it's Monday and I'm worried about my sleep, but on Friday night and Saturday night I can sleep great. Or talk about your menopause or perimenopause symptoms. How is that affecting your sleep? Because guess what? When you see a doctor like myself, I'm going to ask you all these questions. And so sometimes people can come up with their own conclusions by knowing what pieces to think about, what pieces to put together. Since I'm a medical sleep doctor, I'm going to say go get a sleep study. You know, I don't like to have blanket statements, but if anything, aside from prioritizing your health, I really think everybody should get a sleep study. They're so simple to do. You can do it in the comfort of your own home. There's a couple different examples here. It's not so scary about going to the lab, and it's helpful. But if the home test that you do is inconclusive or does not show that you have sleep apnea, it is helpful to go to the lab, because in the lab, we have more parameters. We can look at your brain waves so you know for sure if you're awake or asleep. And that can help us dictate if you have sleep apnea or not. And then see a menopause specialist. You know, it is a special certification now where if you check out the Menopause Society, you can check out where you are in the world and sign up to see a practitioner who honestly all day long they help women go through what you're going through. So I feel like you don't have to feel alone. There's a lot of great resources out there. And if you want help specifically for sleep and you're a self-directed learner, CBTI for insomnia, so the book Say Goodnight to Insomnia by Greg Jacobs, Mindfulness for Insomnia, or the free app CBTI Coach from the VA, they really can help. And honestly, like little to no side effects. You know, there's really no side effect of meditation aside from the time it takes you to do so. And it's a really helpful, and it's free. So these are the resources, again, specifically for cognitive behavioral therapy for insomnia that I like to provide to people. And now my last slide. Thank you so much for everyone's time and attention, for staying till the end here. My favorite quote was, "Planted in each person's soul will sprout." So hopefully you learned a little bit more about women's sleep in perimenopause and beyond, and check out some more information on YouTube. Thank you so much.
Thank you so much, Dr. Cacho, for being with us here today. Before we go through the questions, I do want Amy to post a couple links for us in the chat. She already put up the link to menopause.org, where you can look up for a menopause specialist if you would like to get more help in that area. Dr. Cacho also has a free mini course that you can take. It doesn't cost anything, but you can go a little bit deeper into what we just learned about today. And you can do it at your own pace. You don't have to do it all at once. And then the other link that Amy just shared is the product page for this workshop, where we will have our recording once we have a recording of it. And it also has the slides for you. So if you want to go through the slides again and you can't remember the name of a certain book, or you can't quite remember, or you just want that QR code again, that's where you're going to find those. So we are time limited. Dr. Cacho does have patients that she needs to see. So at this time, I'm going to go ahead and jump to the Q&A. But I did also want to remind you all that Full Plate Living does have additional sleep resources, and all of them have actually been created with Dr. Cacho. And so if you have any more questions, or you want to go a little bit more in depth after the mini course that she has for you, you can also plug into your account at FullPlateLiving and look for some of those workshops that we've done in the past. And I believe we also have an article that Dr. Cacho has written. All right, let's go through some of these questions. What are your thoughts on melatonin?
Ooh, I have a lot of thoughts. So number one, let me just talk about what melatonin is. So it's a natural hormone released in the pineal gland deep inside your brain. And so we actually need it to help us stay asleep. In the US, melatonin is sort of out there like candy, right? They sell that as gummy for kids. It's on, I don't know, every supplement company has one. Do you in fact need it? Well, in clinical sleep medicine, we use melatonin in folks who have shift work or circadian rhythm issue, like their delayed sleep phase. So that means you're more of a night owl trying to live a day person's life. And another condition called REM behavior disorder. So I think I have a video about melatonin on YouTube, but specifically for women in perimenopause and menopause, it may be helpful, meaning it may help you fall asleep faster, may help you stay asleep if the cause is melatonin related, if that makes sense. So, but beyond sleep, melatonin can actually be an anti-inflammatory. So there's studies where, people who are like having sepsis, even babies in the NICU in the hospital who take high doses, some people use it for anti-cancer properties. But that's actually really, really high doses. So typically, if we're going to use melatonin to help with your circadian rhythm, a low dose like zero point 0.3 or zero point 0.5, and it's about 4 to 6 hours before your desired bedtime. Yeah, so there's a dose to help shift your clock. Higher doses, there's a supplement that I like because it's mixed with things like L-theanine, passion flower, hops, a lot of herbs that are really sedating. It has a little bit higher melatonin, like 3 milligrams. The higher doses may be more sedating, but at the same time too, melatonin is not without side effects, right? It has been associated with vivid dreams. Some people get GI upset. Some people actually their blood pressure lowers. And for some people, it can cause a lot of drowsiness or a hangover type effect the next day. So yes, melatonin may be helpful for the right person, but I would say sort of buyer beware. More is not always better. And it also depends on the brand that you're using because some brands are very adulterated, where there was a study in JAMA where there was actually no melatonin, and then other companies had 400 plus melatonin. And then in the study for the gummies, some people are actually putting cannabis in the gummies where it was labeled as melatonin. So a little bit buyer beware. Yeah.
Because I know somebody's going to ask, is
Yeah.
there a brand that you prefer? Or
Yeah.
if you would share like the supplement that you like in the chat for anybody interested.
Yeah. So if you take a look at a website, consumer labs, so like Consumer Reports, but Consumer Labs is supplement companies. They talk about a couple brands like Life Extension and then Pure Encapsulation. And I have no affiliation with these companies. They're just things that I would take myself or give to my family members. Thorn and Natrol. So I don't, in California, we have a store called Sprouts. I don't know if they're available nationally, but they actually have pretty good quality supplements. Costco actually sometimes has pretty good quality. It's like hit or miss. But yeah, I would say Sprouts and even Whole Foods, they're just higher quality brands.
Excellent. Thank you for sharing that.
Yeah.
All right. So would you recommend the CPAP for those who snore or only for those that have obstructive sleep apnea?
Yeah, this is a great question. So, obstructive sleep apnea is diagnosed if you have at least 5 events per hour or greater. Honestly, it's only covered from an insurance standpoint if you have obstructive sleep apnea. I have had, I think, in over 10 years, maybe 3 patients who snore because they didn't meet that cutoff, but the snoring was so loud, their partner was sort of upset with them, and they've tried the over-the-counter mouth guard, so they bought it out of pocket. It certainly can help. But the machines are about $1,000, and every couple months you have to change out the cushion. So it can be costly if you're paying out of pocket for it. So it can help. So basically, all the treatments for snoring are the same as the treatments for sleep apnea, except that if you have obstructive sleep apnea, insurance is going to cover.
Gotcha. That makes it. That is an extra incentive to go and see your doctor for sure if you are worried that you have sleep apnea.
Good.
Would hormones help a woman that is 73 years old?
Yeah, that is a great question. And so I guess one thing that I like to think about is, well, what is causing the sleep disturbances, right? So for someone who's 73, I've had a lot of patients, they were sleeping great up until they hit menopause. And then from then on, it's okay, I don't have hot flashes anymore, but I still cannot sleep. So one caveat, I actually don't prescribe the hormone replacements. I know enough about it to discuss them, and I have a lot of great friends who do, so I send them over to them. So I do have friends who do start hormone therapy, even like a little bit of progesterone in people who are in their 70s or 80s. So I would say it takes someone astute enough to look through your medical history to make sure that you're a good candidate for that. From my standpoint, what I'm going to look at who's someone who's 73 is untreated obstructive sleep apnea. If you have a hard time staying asleep, any medications that may be affecting your sleep, any physical symptoms, waking up to urinate, waking up with pain. And then a lot of what I can do is the thoughts around sleep. Because I have seen, and somebody told me this, and I don't know if this is actually true, like hormones are 50-50. Like you can 50% of people who are on it can still struggle with sleep. So I certainly have seen that they are helpful, but my approach is the holistic approach. Is there a physical reason why you cannot sleep? Okay, as a medical doctor, yes, I can help that. And then I put my integrative hat on. Okay, what else is going beyond that? And I can see a lot of the folks who have done cognitive behavioral therapy who are a little bit older in life, I've seen a lot of loneliness, right? And that's something that hormone therapy can't help with. Maybe they're in a different state as their kids, or maybe their partner, their spouse has died, and now they're worried about who's going to take care of them. And so peeling back the layers of the onion is what I like to do in the holistic model is, yes, I think the hormones can help support the mood, but if we don't get to the core of the issue, we're kind of missing the boat.
That's great. And I like that answer because I think it's going to answer partially the next question as well. Is it true that medications, like those prescribed or over the counter for sleep, actually work against you since they provide sedation, which is different from real sleep?
Yeah, that's such a great question. I like the way that's approached because sometimes I even tell patients, yeah, when you're on these medications, you have synthetic sleep. But if we study patients who are on sleeping pills in the lab, they actually do have less light sleep, more deep sleep, and even longer REM sleep. So I think the question, well, it depends on, I think, what you're trying to improve. I have a lot of patients who are happy on a trazodone, which is antidepressant with a sleepiness side effect, or patients who've been on Ambien for 10 years and now want to get off of it. They are sleeping great, but they know that they probably shouldn't be on it. For me, it depends on the cause, right? Why do you have a hard time sleeping? I would say a lot of folks have a circadian rhythm issue. So that's your night owl trying to live a day person's life, where your true bedtime, if we checked your salivary melatonin level, it's actually peaking later. But the only thing your doctor knows to give you is a sleeping pill. But when we take a look at actually like your sleep diary, how you're sleeping, is if we gave you more light therapy in the morning, we can shift your clock back, or you're actually not going to need a pill. So I don't know if that helps. Yeah, but
it's great.
Medications have their place. But I just like to do the non-medication route because there's a lot of things we can do.
That's wonderful. Anytime that you can reduce side effects,
Yeah.
it's always a good thing. So, and we've heard good things about like therapy in the past, and I know it's used extensively in places like Alaska where you don't get as much sunlight as you should, and it helps a lot with depression as well.
Yeah.
It does help with that. So I'm glad that you brought that up. That was
So
interesting.
even in Hawaii and California, yeah, I think for sure they use it more in Alaska, but I minimally use melatonin to shift someone's clock because light is more powerful at a shifter
That's
of your clock.
amazing.
Yeah.
That's amazing. If you have a chance and you can put something in the chat about a good website to look at about light therapy, that would be awesome as well.
Yeah.
And while you do that, I can put up the next question. I'll give you a few seconds to do that.
Yeah. Well, I'm going to put in the chat. There are eyeglasses called AO that you can actually shine into your eyeballs. So even if your glasses, you could put on top of it. But why put them in the chat? Again, I'm not affiliated with them. Is they have a lot of resources that you can read about light therapy and how it actually affects your circadian rhythm. So it's called AYO. Go AO.
Okay. Thank you. Yeah. All right. Here's the next question. Is there anything that can help with exploding head syndrome that affects sleep?
Yeah, this is really interesting. So exploding head syndrome is a syndrome where you wake up in the night and you feel like your head is actually just like expanding or exploding. And it's in the category of what we call a parasomnia, which is just an abnormal activity, abnormal movement during sleep. Typically in sleep medicine, we're always going to rule out obstructive sleep apnea. For something like this, for the parasomnia category.
Uh-oh. So it looks like we lost Dr. Cacho. She'll be back in a second. We just lost the connection. So while she's doing that, Amy, if you don't mind just putting those two links in the chat again, and that is a link to the workshop page, and then a link also to the course that Dr. Cacho is doing. I think that would be really helpful. And I know you can also scroll back through some of the other links that Amy has shared that Dr. Cacho has been sharing with us that are also very helpful. Welcome back.
Hi, I think we froze. That's okay.
It's all good. It's all good. All right, let me go back to the questions. So we were talking about exploding head syndrome.
Yeah, I'm not sure how much came up, but it's considered a parasomnia, which is just an abnormal movement or abnormal behavior during sleep. In sleep medicine, we always rule out obstructive sleep apnea because it's so common and it can cause a lot of these things. Making sure your sleep is not fragmented, right? Are you getting enough sleep, right? Are there dietary changes that are affecting your sleep? And then if you sort of ruled all those things out, then benzodiazepines sometimes can help too. So it's not common, but I have seen it in training. Yeah.
Excellent. This one is a little bit more specific. And again, we don't give medical advice, so we're not going to focus on that part of it. We're going to take this as a more generalized thing. So if somebody has been on a CPAP for a long time, this person
Yes.
has been on it for longer than 5 years, but recently they're experiencing new symptoms, like they aren't falling asleep or staying asleep, and they're waking an hour or two before their alarm. Would that be a good time to go and redo your sleep study?
Yeah, so potentially, if the machine is newer enough, I can actually create a report and see if there are breathing events happening in the early morning. Yeah, before the alarm, which sometimes, especially if you've been on the same machine for a while, maybe number one, the machine is broken. So sometimes switching it out, actually over 5 years is actually sometimes when you need a new machine. If there's any weight changes, sometimes when your weight changes, especially if it goes up, you may need more pressure. So yes, going to the lab may be helpful, but I would want to actually look at the machine to make sure number one is still functioning before you go to the lab. Yeah.
Excellent. And I'm going to do one last question because we are running out of time. So, what are your thoughts on tinnitus and sleep?
Oh, this is a good question. Number one, it's challenging because tinnitus, it's the ringing in your ear, which some people have been said is associated with perimenopause and menopause, can cause a lot of insomnia. So, um, I would say if you can find an audiologist or a therapist who does cognitive behavioral therapy for tinnitus, like you're in good hands. Usually they're at the Veterans Administration because a lot of vets, because of where they were with combat, have a lot of tinnitus and it can affect their sleep. So yeah, seeing a good audiologist and a therapist that can help restructure your thoughts around it because you may not be able to physically turn down the noise, but you can turn down your perception and the way you feel about that. And that's where the strength of cognitive restructuring can help. Yeah. And then there's actually, I'll put this in the chat too. There's actually earbuds called Oslo, the Oslo buds that are supposed to help with this as well. Oslo, OZLO buds. Yep. So there's for sleep. They're supposed to be more comfortable than having something like this on your head. And you can actually play different sounds through it. So the Oslo buds for tinnitus, if you can't find a cognitive therapist for tinnitus in your area. Yeah,
Well,
thank you so much,
so
everybody.
much. Yeah, this was great. If you guys want to write in what you thought about the workshop, we're so glad that you were here. Thank you again, Dr. Cacho, for all of your time and so much information. I think that all of us can leave with something new that we learned today and something new that we can put into practice, or maybe just a review of the things that we're doing. Again, thank you for joining us. Go look through your Full Plate Living resources and check out Dr. Cacho's free course. And I hope that you all have a wonderful rest of your week. Bye, everyone.